Good afternoon, everyone. I welcome you all to the 12th and final e-dialogue of our monthly maternal nutrition technical e-dialogue series. We started this technical e-dialogue series in January 2021 and have so far successfully conducted 11 webinars with ICMR NIN as the Maternal Nutrition Secretariat. Today, we are honored to have Professor Anurag Kurpad sir as chair for our e-dialogue, Nutrient Requirements 2020 and its Implications. Sir has been the co-chair of Nutrient Requirements Committee 2020. We acknowledge the Director, ICMR NIN, Dr. Hemalata, for leading the team in the forefront and bringing out the Nutrient Requirements 2020 and also for her continuous support to this e-dialogue series. We are also joined by eminent experts in this field, Dr. Madhavan Nair, Dr. Raghu, and Dr. Suparna Ghosh to enrich our session today. All the more, it gives me immense pleasure to introduce Dr. Bharti Kulkarni, who initiated and successfully convened the previous webinars of this series. Currently, she heads the Reproductive Biology and Maternal and Child Health and Nutrition Divisions at ICMR, New Delhi. I take this opportunity to congratulate her on the new role. Before we proceed to the webinar, I request Dr. Bharti Kulkarni to share her insights from the series and to reflect on the journey so far. Over to you, ma'am.
Thank you, Tina. Good afternoon, everyone. Thank you for joining us today. I will not take much time because I'm sure everyone is very eager to listen to the panelists and the speakers and the remarks from the chairperson. I would just like to summarize that we conducted 11 e-dialogues till now. ICMR NIN in collaboration with FOXY. And these e-dialogues are woven into a common theme of strengthening maternal nutrition assessment and care. Each of the previous e-dialogues focused on important issues relevant for maternal nutrition. We started with maternal thinness. We conducted an e-dialogue on maternal obesity, maternal mental well-being, maternal diets and nutrition counseling, maternal anemia. We had one on FIGO checklist, one on using social marketing strategies for improving maternal nutrition, digital technologies for maternal health. We also had an interesting e-dialogue on how women's groups, self-help groups can be leveraged for improving maternal nutrition. Impact of COVID-19 pandemic on maternal nutrition was one of the e-dialogues. We also had on maternal iodine deficiency. So all these e-dialogues covered important issues. And based on this, we are currently in the process of developing training e-modules on maternal nutrition. And it gives me immense happiness to be here at NIN for this concluding e-dialogue on nutrient requirements, which has been a very, very important issue. And we had requests from our partners to conduct this e-dialogue because people have a lot of questions and concerns. I'm very happy that we have our chairperson, Professor Anurag Kurpad, leading nutrition experts in the world, to be available to chair this session today. And we have expert panelists and speakers, and we really look forward to a very enriching e-dialogue today. Thank you. Over to you, Tina. You're mute. Yeah.
Yes. Thank you, ma'am, for walking us through the insights of all the technical e-dialogues which have happened so far. Now I'm privileged to introduce our chair for today's webinar, Professor Anurag Kurpad sir. Sir requires no introduction, but still, sir is the founding dean of St. John's Research Institute. Sir is the co-chairman of ICMR Expert Committee on Nutrient Requirements of Indians 2020. And also, sir is the chair and expert member of many national and international committees, scientific panels, and technical advisory boards. I now request the chair, Dr. Kurpad sir, to give his opening remarks.
Thank you, Dr. Tina. And of course, it's a great pleasure to be here with old friends like Dr. Bharti, for whom I have the most immense respect and admiration. And I'm really pleased that she is now at ICMR headquarters with a very important role in guiding nutrition in this country. Thank you, Dr. Bharati. I also want to thank the other organizers, Dr. Hema Divakar, and of course, I'm really pleased to be sharing something that Raghu Pulakandam, who's a great friend now, is going to be talking about. He is truly an expert in nutrient requirements. And then, of course, we have the stellar panel of Suparna and Madhavan Nair, who are also old friends. So I just feel like I'm back in some old friendship metaverse. So I'm really happy about that. So thank you. I think this topic is really important. And I want to, before we start, to pay tribute to my co-chair in the Committee for Determining Nutrient Requirements, and that is Dr. M.K. Bhan, who was a guiding light and really set us on the path. And it was really illuminating for me to work with him, and I miss him deeply. I'm sure all of you do too. So with that tribute to Dr. Bhan, I do want to say that this seminar is really important because the new requirements have defined a new metric. Well, it's not a new metric, it's been around forever, but it is new to many in India. And it's called the estimated average requirement, which I think Raghu will deal with. So I'm not going to talk too much about it, except to tell you that every new metric that comes along, people are upset about it. It's a change in the old ways. So I think we have to think about the way things are done. We're also trying in India very hard to be part of the harmonization of requirements across the world. And this is now going to be discussed at the IUNS conference in Tokyo in December this year, in a session that's held by WHO, FAO, the IOM, that's now called NASEM, and the Gates Foundation. So there's a lot of interest around trying to come to a common way by which we define the requirements. And of course, the CAR metric is part of that. And this is definitely because we are finding gaps in the nutrient intake in populations. And the question is, if there's a gap, is that gap in relation to the EAR or is it in relation to the RDA? These have different implications. And that's why I think it's so good that we are having this meeting, because we will learn about the EAR. And more than that, there were times, and especially when I was working with the WHO, FAO, and UNE groups to define protein requirements, we often wondered to ourselves that we set these requirements per trimester, because we're looking at gestational weight gain per trimester. But, programmatically, we just generally work with one single requirement during pregnancy in the second and third trimesters. So we often wondered whether we should just have a requirement for the first half and the second half of pregnancy. That idea went nowhere, obviously, because clinically it's important to go by trimesters. But I'm sure you'll all have ideas about that. And of course, I don't know if you're discussing lactation as well today, but that's a critical point. Lactation is an even more stressful time for the mother to deliver nutrients to the baby. So both pregnancy and lactation, to me, are really stressful, demanding times for the mother. She requires to eat a better diet. And the question is, how do we get her to eat that diet, and what is the requirement? So I'll stop there, because I know by now you must be tired of listening to all this and you want to get to Raghu with the meat of the presentation. So I'll hand over to Raghu now. Raghu, it's all yours.
Thank you, sir. I'll just share the screen. Is it visible?
Yes, it is.
Make it in a presentation mode.
Yeah, can you please go to presentation mode?
I am in presentation mode on my screen.
Maybe you can try to close it and do once again.
Is it in presentation mode now?
No, sir. Not yet.
Not yet. You can just advance the slides there if you wish, Raghu. Manually.
Yes, sir. And is this fine?
We are on your first slide. Can you please try going to your second slide so we know it moves?
Yes, sir. It is in second slide now.
No, it's not moving on the main, on this picture. That's the problem. Yes, now it's come. Now it's come. I don't know what you did, but now it's working. Okay, we're all set then.
Yeah, good afternoon, all of you, and I thank Dr. Bharati and team for giving me this opportunity. And it's always suffocating to present in front of a legend like Dr. Anura. But I'll try my best. As you know, the ICMR 2020 nutrient requirements come out recently, and there is a buzz around what those. There could be a lot of implications, and there is a buzz around that. Before going into the requirements, because I understand many of the participants are in programmatic testing, might not be in touch with the biology, I just want to spend a couple of minutes on this slide about what is nutrient homeostasis. There is an intake, and the digested nutrient is absorbed, and it gets into the tissues as reserves, and then into the functional pool. There's a two-way. The absorbed nutrient gets into the blood and gets into the tissues depending on the equilibrium. If the blood concentrations are good, it gets into the tissue. If the blood concentrations are lower, then it comes into the blood from tissues. And then it gets excreted, and there is some reabsorption during the excretion pathways. And the overall, the intake and then excretion. But there are dynamic interactions between all these steps. For example, intake is low, the absorption or bioavailability goes up. And if the functional pools are low, even then the bioavailability or absorption goes up. Its storage and functional pool is the same. And for some nutrients, absorption might not alter during, intakes are lower, but its reabsorption increases. Therefore, the overall retention of the nutrient is higher, and therefore the excretion comes down. These are all dynamic things, works with each other so closely. But the nutrient requirements, we assume that are for a person who is in balance. That is, absorption intake equals to the excretion, or absorption equals to the excretion. So normally what happens in deficiency is either absorption goes up or excretion comes down. In excess, absorption comes down and then excretion goes up, depending on the type of nutrient that we are looking into. And then what are nutrient requirements? The amount of nutrient required to maintain steady state in healthy subjects. That means intake equals to expenditure in the case of energy, or absorption equals to excretion in the case of other nutrients. There are two requirements. One is the physiological requirement, which is quantity of absorbed nutrient required to maintain balance. And there is a dietary requirement, that is quantity of dietary nutrient required to maintain balance. Absorbed nutrient and the dietary nutrient. So how do we, actually dietary nutrient is derived from the physiological requirement. Well, how we do that is physiological requirement is adjusted for absorption or bioavailability to derive the dietary requirement. So the question is, does requirements for all population are same? They are not. There could be three major kinds of variations possible. One is age, physiological group specific, and where additional needs, additional nutritional needs are required for growth and the tissue mass accretion. And there is inter-individual variation in requirements. For example, somebody needs X, but somebody needs Y, even when they are at balance. That could be because of genetic or many other, not really understood why there is inter-individual variation. And there is, again, physiological variation, which is deficiency, normal, and excess, which is not relevant in deriving the requirements, but these two are age and physiological groups, specific requirements, and inter-individual variations. So if you consider a normal population, healthy population, where they are all healthy, that means they are at balance, even in the same age and physiological group, their requirements vary. Please note that this is a requirement distribution, not an intake distribution. So this variation is because the inter-individual differences in absorption, tissue size, reabsorption efficiency, or the rate of expression. But this is what we are going to deal with. There is inherent variation in requirements of different populations. But we want some metric to show the requirements. Therefore, this is a normal distribution. It is expected that if you measure the requirements of large number of population of same age and physiological group, the requirements are expected to be normally distributed. In this normal distribution, the mean of that requirement is called estimated average requirement. You can see that the metric name itself defines that is average requirement of a population, and there is a plus 2 SD of that requirement is recommended dietary allowances. This is very important to understand because 97.5% of the population require less than this amount to be normal. The other word is, other metric is the lower nutrient reference intake, where below which, this requirement is good for only 2.5% of the population, but below which the risk of, getting into deficiency increases. All these metrics are specific to age, gender, and physiological. So how these requirements are derived? First assumption is we take healthy population. It's not assumption, but we collect the data from the healthy population. Either it could be a balanced study or a factorial computation or based on functional markers. In case of energy, we measure exactly how much is the energy expenditure. And then based on that, to balance that expenditure, we provide the allowance for, intake allowance. And then there is functional markers where we define a normative value for a specific enzyme that requires a particular nutrient in case of folic acid and thiamine, etc. And to maintain that level of enzymatic function, the plasma level required we compute, and then we adjust it for bioavailability to arrive at the dietary recommendations. But most of the requirements are computed through factorial computation, where we measure the basal losses which encompasses urinary losses, fecal endogenous losses, and a variety of losses, including the lactation, menstruation, and the additional needs for growth for the young children, as well as during pregnancy for the respective body weights. And after that, we pool these losses and additional requirements for growth and associated variance, because each of these factors comes with their own individual variation. And all those are pooled and they are again converted into per kg body weight. This is the requirement per kg body weight. That is the loss per kg body weight. And this is converted into physiological requirement, which is adjusted to a reference body weight. The reference body weights are from WHO, the ICMR 2020 used, and for some age groups, NNMD data was also used. So if you consider, for example, if requirement is 0.1 milligrams per kg body weight, then requirement for reference weight of 60 kg will be 6 mg. And then this physiological requirement, we convert that into a dietary requirement by adjusting for absorption or bioavailability. Let us say if the physiological requirement is 6 and the bioavailability is 10, the dietary requirement is going to be 60 mg. So for at least for iron and zinc, most of the requirement is extremely elevated because of very poor bioavailability. And this is the 3 metrics that ICMR 2020 provides. One is the estimated average requirement, recommended dietary allowances, and there is another metric called tolerable upper limits, which is a safe, beyond which the risk of toxicity increases. So these are not, again, I just want to stress, these are not intakes, but distribution of requirements. The TVL is tolerable upper intake, beyond which the risk of toxicity increases. And this is derived mostly from toxicological studies. I just want to emphasize that this metric is not derived from a long-term study, mostly the acute dose related studies. Therefore, there is a lot of uncertainty associated with it. Therefore, it is always better to maintain the intakes lower than this tolerable upper limit. And the difference between ICMR 2020 and 2010 is ICMR 2010 gives a single value of RDA based on the knowledge available at that time. Even in 2020, except in the case of energy, where in the case of energy only ER is specified, but not RDA, because we don't want to increase the weight. And these are the definitions which I already dealt. Then you come at the physiological or dietary requirements. You see for different age groups, there is physiological requirement. I'm just taking iron as an example because many people will be interested in it. And at the very end of the presentation, I have just copy pasted all the requirements if someone wants to refer it to them later. You can see the physiological requirements are about 1 to 1.5 milligrams, and the absorption assumed is this, and you need this 11 to 15 mg for adult men and women. The highest requirements are in pregnant women, and then followed by lactating women. And you see the variation that is adjusted. That is, this is the 50th mean of the distribution, requirement distribution, and RDA is 97. That is RDA ER plus 2SD is the RDA. But you must remember and clearly understand that the RDA requirement is only for 2.5% of the population. 97.5% of the population require less than this value. And RDA for 2010, you can see that the single metric, it is either close to the ER or it is higher than the ER. But now current RDAs are almost always higher compared to, or closer compared to the RDA of 2010. And there is another metric of TVL, which is given for all the nutrients. I'm just showing the example of iron. For adults, it is 45, and then for the infants and young children, it is 40, and then in adolescents, it is 45. Essentially, this is a population metric. This is a highest requirement for a population, and this is the intake level that one should not exceed at any time point through regular intakes. And there is another important metric, recommendations that are often ignored is the acceptable macronutrient distribution range, AMDRs, which suggests that the energy should come from carbohydrate, fat, and a quality protein in specified ratios to be in good health. And most of the time, at least to my experience, this thing is underlooked, and the micronutrients and other things are kind of high. And then how do we interpret these requirements and implications? Do these reference requirements suitable for deficient subjects? These are the questions kind of I faced from among my colleagues. So I'm trying, and I thought many people would have these questions in their mind. In deficiency, the physiological requirements are higher, but the dietary requirements are low. Because as we discussed earlier, the nutrient retention goes up, absorption goes up. Therefore, these requirements help correct, that is the ER, to a large extent, even in deficient population, but the rate of correction is very, very slow. So when you assess the benefits of health are very high in correcting the deficiency in short term, you aim to targeted therapeutic supplementation in vulnerable groups in short term. That is ideal. And the next question is how much to supplement, whether it is ER or RDA. Actually, both are not, and I'll come to that a little later. So, and then do these dietary requirements are cast in stone? No, this requires constant, this is contextual interpretation is needed. For example, you see in a meal, a guava which is rich in ascorbic acid is given, you can see the bioavailability almost doubled from 9.7 to 14.2 in girls and 8.6 to 10.6 in boys. So when you put this in context of requirements, if the physiological requirement is 1.3 and we adjusted it for 8% bioavailability in the current requirements, which led us to a 15 mg of ER. But what if the diet is very good with rich in ascorbic acid? The bioavailability, let us say it is 16%, then our requirements are 7.5 mg. Therefore, this is very, these requirements are, because of a large population, these requirements are like that. But they need to be interpreted with caution in different contexts. And you see, just another example, if you look at the physiological iron requirement in pregnancy, it is 2.55, way beyond any other physiological group. But if you look at its ER, it's not that high. That is because the bioavailability is adjusted, which is higher. And its RDA is also, closer to this because the variance is low. Quite often we are getting questions like why the RDA for pregnant women is lower than the normal woman. That is because the variance between in requirement is lower, therefore RDA will be lower. But if you look at ER, it will be higher. It is 6 milligrams higher compared to a normal. And again, let us consider, beta carotene is the precursor for retinol. But retinol and major portion of the vitamin A that come through a vegetarian diet is in fact from carotenoids. If you look at the dose of carotene and the carotene conversion ratio, as the intake goes up, the conversion ratio goes up. That means what? If for 1.5 mg of intake,
Hello, can't hear you.
what I want to emphasize is increasing the intake may not translate in expected benefits. It's all controlled by beautiful physiology. And then the implications of nutrient requirements. First, let's discuss my experience, at least with ICMR 2010, is the dietary deficit computed against the RDA and attempted to fill this gap through fortification or supplementation. And the statements that I often read was 70% of the population consume less than RDA. And therefore, you want to fill that gap to meet 100% RDA. But now we know that the population requirement is not the RDA, but it is ER. So based on current knowledge, the true meaning of above statement, as I feel, is 30% population consumes more than their requirement, which is actually good. We are not that deficient because 30% population is consuming more than they require. And then food fortification was decided based on the RDA, where 30 to 100% of RDA was considered for iron and or 1/3 RDA for other vitamins. But as I deal it with later, neither of these metrics are suitable for fortification. Then the implication of nutrient, very, very important implication is it helps us assess what is the level of dietary inadequacy in either an individual or in a population. Let us consider a case of one particular individual. This is your requirement distribution, let us say 0 to 30. And if you know the intake of a person as 10 milligrams, and all the area under the curve, right side of this is his risk of probability of deficiency. For example, this is a 5 quartile. So 85% possible that this person is likely to be at risk of deficiency. But since we don't know this individual requirement, we don't know where this particular person's requirement falls. Therefore, we should treat him with RDA because the requirement of him is almost always likely to fall below this level. But this should be only in short term and it should be supervised. But the same is not the case within a population group. In a population, the requirement distribution, the intake distribution is often skewed, and it's very difficult to use a simple cut point. But it is possible when variance in intake is higher compared to the variance in requirement. But in a large cases like what we deal with the dietary intake data, the probability of risk of inadequate intake against entire distribution needs to be measured. Many people say deficiency, risk of inadequacy with respect to ER or RD. Actually, it is risk of inadequacy equation, the probability equation has both these metrics. Therefore, we are measuring the risk of inadequacy against the entire requirement distribution. That means if the population intakes matches with ER, that is the ER, that is the requirement distribution and the intake distribution superimposed, the expected inadequacy or adequacy is 50%. But if all the population consumes at the RDA level, the expected inadequacy is 2.5% and the expected adequacy is 97.5%. I know it is tempting to push everybody to 97.5, all the population to 97.5% adequacy, but it has its own problems. I'll come to that. Now, I just discussed that if a population, let's consider a scenario of a perfect case where every individual requirement matches with their intake. That means we know 10 people, we know their intake, we know their requirement. And if we superimpose them, they exactly match. And then if we use that data to compute the probability of risk of inadequacy, it will be 50%. That itself shows that the normative value for dietary inadequacy of adequacy or adequacy should be 50% in a population. And if it is not 50%, the goal of all interventions, I want to emphasize here all interventions, it could be supplementation, fortification together, is to achieve the risk of inadequacy, adequacy to 50%. At least we have some data evidence to show that if the diet, we measured the vitamin A diet, I'm sorry, I will not put the label here, but this is the vitamin A inadequacy in under 5 to 9 and 10 to 19 years children. The dietary inadequacy estimated from NNMB and NSSO data is 68, 69, and 78. And as I said, we expect 50% in normal population. Therefore, if you subtract this from that 50, it comes to 18.8, 19, 28. This is a true prevalence of inadequacy. And when you look at its close match with biochemical deficiencies, 15.7, 19.3, 14.4, this is kind of reassures that what we are thinking is actually true. And then what should be, I'm sorry for this spelling here, what should be the ideal approach to increase the intakes? Now, let us say there is EAR or the RDA or the, let us say if you are at the lower limit of intake, the best way is to push these intakes towards the EAR and ensure that nobody crosses the, comes close to the TUL level. Set the target to achieve 50% dietary inadequacy and ensure exposure to TUL is very minimal, and also monitor the benefit and tox. And if these are this is a paper published in Journal of Nutrition by Dr. Anuja's group. You see the dietary inadequacy in women of reproductive age against the old RDA. This is around 80 to 90%. But when you use the ER estimated from the current requirements, it is grossly close to 50%. And if you supplement with, now at least with current fortification standards, you're likely to cross the 10 mg. But if you take 10 mg as an input from the fortified foods, the inadequacy goes down very low. But at the same time, you start finding in few population groups, at least in few states, there is risk of inadequate intake. But if you use the 24 mg, that is coming from both supplementation of women of reproductive age, their IFA is supplemented, and fortified, as well as their usual intake, we start seeing that across different states, the TUL, the risk of crossing the TUL is very, very high. And this, you see in the state is 54%, which is very, very high. And we should, make sure that this practice is discouraged. And the implications of ICMR 2020 requirements are ER should always remain the population metric and not the RDA. And the goal of all nutrition programs together should be to shift the intake distribution close to the requirement distribution. That is to achieve 50% dietary adequacy or inadequacy. Considering large interstate variations, universal approach may not be feasible in many cases. And we should revise our approach based on dynamic and contemporary scientific evidence. There is nothing new that we are going to do. This is always being done, and we should do this again. Thank you. And these are the potential references. This is ICMR 2020 book, which almost covers everything that I presented today. And I recommend all of you to read this particular review published in NFI Bulletin in 2015 and the contextualizing principles of iron fortification again in NFI Bulletin by Dr. Nair. Thank you so much, sir, and I'll be happy to. I just pasted some of the RDA and TUL tables if somebody wants to refer later on. And I understand these slides will be shared with all of you. Thank you.
Now we'll be moving forward to our panel discussion. I would like to introduce Dr. Hema Divakar ma'am. Like madam has been there right from our first webinar, and this is our 12th webinar today. And Dr. Hema comes with the same energy as always. And it's my privilege to introduce her. Madam is the chair for FIGO Well Women Healthcare Committee. She's the medical director at Dibakar's Specialty Hospital, senior consultant gynecologist with over 3 decades of experience and expertise in women's healthcare. I request Dr. Hema to take over. Over to you, ma'am.
Namaskar. Thank you, Tina. And it was just about 400 days ago that Bhartiji, Vani, and myself met and said we have to bring nutrition to the forefront and disseminate a lot of information between different stakeholders and our beloved audience. And we said once is not enough. So we met a dozen times, month after month, on the e-dialogue series. And as you have been told again and again, this is the 12th of the series, grand finale of the sort for the vision that we had for deliberation for a whole year. So once again, on behalf of all of us, thanking all our stakeholders and partners, we welcome all our beloved delegates, and it's indeed my proud privilege to introduce a very distinguished panel of speakers in this session. And keep your thinking caps on and the questions ready, because as Dr. Kurpat said, we come from the OBGYN practicing clinicians space, and he mentioned first, second, third trimester, or first half of the pregnancy, or second half of the pregnancy, and so on and so forth, and lactation also being a very important period in the nutrition space. But dear friends, we must confess that we as clinicians have 2 constraints. The 2 C's are the time constraint for counseling and the thorough lack of understanding for calorie counts and calculations, and it's mind-boggling. And today's discussion so far with Raghuji making a brilliant presentation yet again brought us to the focus that the clinicians have not understood it all. So let's hear more from our distinguished panel, Dr. Suparna Ghosh, who is the professor and head community nutrition at the Public Health Foundation of India, with the areas of expertise in public health nutrition and implementation research, which is very, very crucial, because the gap between knowing and doing, that needs to be bridged by the lessons learned with the implementation research. She has worked as a consultant in Health, Nutrition and Family Welfare Division, and she served as the National Coordinator for the World Bank Assisted Capacity Building on Food and Drug Safety under the Ministry of Health and Family Welfare, Government of India. Again, I underline and underscore, capacity building is so crucial, because there may be a demand out there, but unless the supply through the touch points of all the healthcare providers and the like, the capacities of disseminating the quality of information that is needed is so very crucial. So Suparna Koshi is going to address us on a very important issue of assessing the nutritional inadequacies using the nutrient requirements 2022 values. So much of the science and mathematical confluence that you saw in Dr. Raghu's presentation. Her deliberation will be followed by yet another stalwart, Dr. K. Madhavan Nair, who is a scientist F at ICMR, Institute of Nutrition, Hyderabad, chair of the scientific panel on labeling and display FSSAI, and member of many committees and panels and groups at Food Safety and Standard Authority of India. He will be speaking to us on implications of nutrient requirements 2020 on the labeling regulations for packaged food and nutraceuticals. I must confess that all of us as clinicians, sir, are looking for a quick fix method. We may not understand much, but if there is a label and even the consumers can figure out what's right, what is wrong. So I do hope that the deliberations by these two experts will throw more light into our understanding of doing the best for the population. So all yours, Suparnaji, to make your presentation on taking us further in our understanding.
Thank you, Dr. Hema. I'll share my screen. Is it visible?
Yeah, Suparnaji, if you can put it on full screen, yeah.
Is this okay?
Yes, thank you. Yeah, that's fine.
All right. So firstly, good afternoon all. And I would like to thank NIN and the other partners for inviting me to this technical webinar series. And I can't agree more on this, that we need to strengthen maternal nutritional assessment in the context of their dietary and the nutritional intake with its correct interpretation. This is very crucial. And for this, we need standards, we need cutoffs that give us precise estimates on the level of dietary and nutritional inadequacies. What are we comparing our data with? We need to have something, the gold standard that we take should be well-derived, should be evidence supported, and should be able to give us the right picture on the status of malnutrition in the country. So, and this holds especially true when we have a diverse range and level of malnutrition that we are presently seeing in our population, where on one hand, we might need to make sure that some sections of our population are not exposed to too much of nutrients in the presence of multiple food-based and nutritional supplementation strategies. Some of them are universal and which are being simultaneously implemented. And on the other hand, we have nutritionally vulnerable population who are finding it too hard to even fulfill their normal nutritional requirements despite all these interventions. So at this point, it is important to have correct estimates of the nutritional requirements of our population, and this will lead to better estimation of actual risk of nutritional deficiency amongst the different socioeconomic groups, levels of stratas of, population, keeping the cultural diversity and other contexts in mind, and accordingly inform policies. So this is the topic of my presentation, assessing nutritional inadequacies using the EAR 2020 values in reproductive age group women in the vulnerable communities of India. So this is the outline of my presentation, where I will be giving a background of the work that I have done and I'm doing with the vulnerable tribal communities of Jharkhand, how we used the new cutoffs for assessing the dietary intake and the nutritional intake of that population, especially using the new EARs for estimating the risk of nutritional inadequacy and discussing them in the context of our findings. So the data that I'm going to share with you is on the indigenous food study, where we have looked at the dietary diversity and nutritive value of indigenous foods in addressing food security and nutritional status in vulnerable tribal communities of India. And here, the research question we tried to address was that despite living in rich, biodiverse food environments, several of our indigenous communities, and despite focused programs for the tribal groups, the tribal welfare departments working with the health, with the Ministry of Women and Child Development, yet we are seeing such high levels of malnutrition, reported malnutrition in these communities. So where are we going wrong? So, or what are the possible factors that might be affecting the intake as well as its translation into nutritional status? So for that, our study objective was first to characterize the food environment, then assess the nutritive value of several nutritious indigenous foods these people are eating, which are perhaps also underutilized to some extent. And then the third objective is something which I'm going to present today, is estimating the contribution of these foods to nutrient intake and the nutritional status of the communities, especially women in the reproductive age group and children. And then informing the development of interventions to support indigenous food consumptions. And here we propose to use linear programming to make contextual solutions based on the information that we gather from this particular population. So a bit on the sampling framework, because all these actually informed how we calculated the usual intake of the population. So we firstly, at the first level of sampling, we did a purposive selection of blocks which were inhabited by specific tribal groups. So we worked on 4 tribal groups, and we picked up purposively those blocks which had higher concentration of those tribal groups. And then we randomly picked up the villages and then the households in those villages which had women in the reproductive age group, but they were non-pregnant, non-pregnant, and children in the age range of 6 months to 56 months, to specifically look at their dietary intake profile. So we looked at the nutritional status assessment, and as we popularly use the term ABCD, we looked at the anthropometry, we looked at the dietary intake of this population. We did some biochemical assessments, and here we used some novel methods of undertaking multi-assays on a finger prick sample and looking at screening them for the common nutritional deficiencies, including vitamin A, iron, and also looking at some of the inflammatory biomarkers to adjust their values against those nutritional biomarkers. So now I will come to the focus of this presentation, which is the method of dietary assessment. Usually in nutrition, we use multiple methods and then triangulate the information to get a good representation of the diet that is being consumed by the population. Here we used a 2-day non-consecutive multi-pass 24-hour dietary recall method, but we did a lot of training and we did a lot of capacity building of the nutritionists who we were working together in order to get the exact picture of the diet that these communities were consuming. So the dietary recall required us to, elicit information on not only the food, not only the standard recipes, but exact recipes, what they were consuming, so that we got a very accurate estimate of the raw foods that these communities were consuming. So we used food recall kits, portion size estimation kits, and others. The first important thing to get dietary intake data accurately is to get the right estimate. This was also, supported by a food frequency questionnaire, but for the purpose of calculating the usual dietary intake, we used this data. Now, the dietary intake were then converted into nutrient intake. And for that, we used the Indian food composition tables and supplemented it with number of new foods that we identified, not new foods, but the indigenous foods for which we did not have the nutritive value in the IFCTs. We published all those specific values added to the IFCT. This IFCT is adapted in a validated software, which is called DietCal. And we used this particular software to calculate the actual raw food intake of the population. Again, a word of caution, we have the raw food composition table with us. So the nutrient retention factor is not being taken care of in our kind of estimation. So we just converted the raw food intake into the nutritive value, and we calculated the 2 days dietary intake converted to nutrient intake in our database. Now, at that point, we realized that these 2 days of estimates, and I was glad to see this term usual intake in Professor Raghu's presentation as well. And usual intake is something which is very crucial in case we want to compare it with the estimated average requirements or RDAs for that matter. Because when we talk about estimated average requirement or RDAs, we are talking about long-term consumption. So the long-term consumption of the population should be compared with their requirements. And that's why there was a reason to convert these 2 days dietary intake into usual intake. So, and the reason is very evident that an individual does not have a constant dietary intake from day to day. His or her daily intake varies both in amount and the type of foods and drinks consumed. So this is intra-individual variation. And the 1 day dietary intake cannot reflect the true usual intake of the individual. And that is the reason why we do multiple days intake. However, even if we are doing multiple days intake, like average of 2 or 3 or even 7 days, would lead to a biased estimate as it omits within person variability by simply averaging out the consumption. So variation also, on top of this, variation also exists between persons in their nutrient intake averaged over time. So that is the inter-individual variation. So what do? The usual dietary intake is the long-term average daily intake of a nutrient or food. And why do we need usual intake? Because dietary recommendations are intended to be met over time, and diet health hypotheses are also based on dietary intakes over the longer period of time. Statistical modeling comes as a rescue for us here, and this has been used for years now in the nutrition community, where they have used statistical modeling to mitigate the limitations of 24-hour dietary recalls and derive usual intakes. One of the method is given by the National Cancer Institute, NIH, where they are assessing the long-term average or usual dietary intake, which builds on the strength of 24-hour dietary recall and can also employ the food frequency questionnaires. The premise of the NCI method is that the usual intake is equal to the probability of consumption on a given day times the average amount consumed in a day. So there is a probability factor which is added to the day's intake of the population. So if you have 2 days intake, we'll add that probability factor and try to have a more representative nutrient intake or dietary intake for comparing it with EAR. And what is the statistical method? I won't get into the detail, but if the data is not normally distributed, they are first transformed, then the variance is reduced, and then they are back transformed to get the usual intake data. In simple language, we look at the data, we transform it, reduce the variance, and the outliers are sort of adjusted to come closer to the usual intake of the population. And accordingly, we get a better estimate of the usual or the habitual intake of the population under question. So that usual intake is then compared with EAR, and that's what we did, and we did not compare it with RDA. Now, the reason why we did not do that has nicely been explained by Professor Raghu, and we just followed those guidelines. And as has been rightly pointed out by Dr. Hemalata, EAR has been there, the concept has been there. It's only for us that we did not adapt it, though for energy we had it for a long period of time. It's only for the other micro and macronutrients that we have now established EAR. And it is rational or normal, because when we are looking at the population level consumption and we are trying to understand how well the population is consuming, we are taking the mean of that population and comparing it with the RDA. We are not understanding that a major portion of that population is at the average level of intake. And when we are trying to, assess the adequacy of that diet, why not compare it with an estimated average requirement as compared to a value which might be used when we are talking about the desirable intake of the population. So when we are talking like this population must consume this amount of food, micronutrient or macronutrient, so that, majority of the population are not at risk of deficiency, it's fine. But when the population has consumed the diet and we want to assess the dietary intake of the population, might as well consume it with the EAR, with the understanding that 50% of the population will be below that and 50% will be meeting that. And that is the EAR cut point method that we used. So yes, that is a kind of rationale. Now, if we look at another data set, which has clearly shown how the various, micronutrients were assessed based on the two kinds of approaches, which is the EAR, the RDA, and the probability approach. What we found is with the probability approach, and that is what when we defined the usual intake, we found that the levels were not somewhat, but very close between the two. So if you see with the prevalence of inadequate intake with the probability approach as well as EARs, they were much, much closer. So why is EAR better to assess population nutrient adequacy? I have already explained. And EAR provides a good estimate of an individual's requirement, taking into account the net requirement and the absorption. The EAR cut point method yields a good estimation of the prevalence of inadequate intake and limits over as well as underestimation of the prevalence induced by the RDA. Hence, this approach to assessing nutrient intake is more informative than former method, which relied solely on the recommended dietary allowances. So we went ahead and did the assessment of the nutritional inadequacy of, or the risk of nutritional inadequacy of tribal women in Jharkhand. What we did was for different nutrients, we used, if the distribution was skewed, which is true for iron especially, we used the probability approach method, and for the others, we used the EAR cut point method. The EAR cut point method, what does it do? It's after computing the usual intakes, which I've explained, the prevalence of nutritional inadequacy was estimated using this method, where we simply calculated the number of women with usual intakes of the nutrients below the EAR, and the proportion of women with usual intake below EAR were then considered as inadequate in terms of, were considered to be having nutritional inadequacy. So for the first tribal groups, which we did in 2019, and I remember contacting Dr. Kurpad about the EARs, and he said it's going to be published soon. So we used some kind of adjustment, which was recommended in literature, where we considered 0.77. We multiplied the RDA values with a factor of 0.77 to get the EARs for our population. And for the EAR of iron, we used the study by Ghosh et al., which was shown by Dr. Raghu in his presentation for looking at the EAR for iron. And then for the other two tribal groups, by that time, we had the EAR estimates available, EAR 2020 available, so we used them for assessment. For the probability method, on the other hand, it is not so simple, because again, it goes with the assumption that some of the nutrients are not distributed normally, and we just can't put EAR as the cut point and say percentage of people below are adequate, are inadequate, and percentage of people above EAR are adequate. So we use this particular probability approach, where you can see in this table, we use some standards given by Allen et al., wherein they gave for a particular percentage of bioavailability. Again, the iron estimation, if you remember the slides from Professor Prabhu, 10% bioavailability, there are some probability of inadequacies given. So at different levels, so we had women in the age group of 15 to 49. So those who were in the 15 to 17 years were put under this category, and those who were above 18, that is adults, were put under this category with 10% bioavailability. We said if somebody had an intake of 7.5 milligrams per day, has the probability of 1, which shows that yes, they are 100% at inefficiency, have inadequate intake. Whereas as the level of intake improved, we multiplied it with the probability of inadequacy to get the actual percentage of women who were inadequate. Adding the total gave us the level of inadequate intake, and unfortunately, our population is really impoverished and is not accessing the IFA supplementation, which is very much there. And the weekly supplementation is also there under the Anemia Mukh Bharat. But we hardly found them actually consuming that amount of iron through supplementation. But if we calculated the diet was grossly low in iron. And as a result of which, even if we would have used EAR cut point method, we would have had 100% population who were consuming less. And using the probability method also, we found the same results. So the nutrient inadequacy, or the risk of nutrient inadequacy in the 3 populations, if you see, this was the work we published with the values which were calculated based on the RDA, multiplying it with 0.77, except for iron. And we found, as you can see, most of the population was below the EAR for their particular age and physiological status. In all the 3 populations, we found that even using the EAR cut point method and the probability method, most of the micronutrients, most of the macronutrients, except for proteins, because they were eating a lot of rice, and here the question of protein quality comes. Like some of them were able to meet their protein requirements, but at the cost of quality. As you can see, around 25% were not protein inadequate, risk of protein inadequacy, but the rest were all at risk of protein inadequacy. And same was true for most of the nutrients. So I don't want to go into the details of each and every nutrients, but as you can see, our population level consumption was really poor. And this was despite the fact that we modeled our data, we converted them into usual intake, we took care of the outliers and everything. Despite that, and using the EAR cut point method also, we found that several of these women were in the range of risk of having nutrient inadequacy. So, and then we sort of, looked at the anthropometric data, and we did find that the prevalence of chronic energy deficiency in these women were higher than the state's average, as well as the national level, the NFHS4 data. When we compared, we found all the 3 tribal group women demonstrated high level of chronic energy deficiency. So in the conclusion, I would say that estimation of nutritional adequacy using EAR is a valid approach, as it limits over as well as underestimation. And but by comparing the usual intakes with EAR, we found that 3 of our tribal groups were at high risk of nutritional adequacy. With this, I will finish my presentation. Thank you.
Thank you so much, Suparna. That was indeed very eloquent and insightful. And there's a lot more food for thought for us in the clinician space as well. But who is to calculate, who is to disseminate this information, and how it reaches the last mile? So there is a lot that we need to think and act upon as well. In the international organization PIGO, there is a tagline for all the clinicians the world over saying, think nutrition first. Well, unfortunately, we are still in the thinking stage. It has to get translated into action, which forums such as e-dialogues will help us move the needle ahead. So now we present you, ladies and gentlemen, Dr. Madhavan Nair, who will speak more about the regulatory aspects of the labeling. What implications does this new concept have when packaged foods have to be labeled? Over to you, Dr. Nair, and after which we will take the questions from the audience and other esteemed panelists as well. So.
Thank you very much, Dr. Hema. Can I request the sharing my presentation from Richa, can you share my presentation? To avoid confusion, I thought it's better give it to the organizers for projecting it. Richa?
Yes, sir, I'm doing it. Give me a
Yeah.
minute.
Yeah, I think it's again a wonderful opportunity for me to be with the practitioners and probably the non-practitioners and discussing this issue, because I find it very enriching experience, because that's the best way to translate these numbers into what is useful for the public. And I thank the organizers for giving me this opportunity and including me as a panelist. And I really like this type of dialogue. It is because, I mean, there are a lot of stakeholders who don't understand many of these things. They ultimately see only the product and maybe only the taste and other things matters for them rather than the nutrition part of it. The topic I want to discuss with you is the implications on labeling regulations for prepackaged foods and nutraceuticals. When I went through the the invite, I saw this part in the invite, that the objective is to ensure universal and equal coverage of interventions, as well as to contextualize the nutrition care package for at-risk mothers suffering from obesity, extreme thinness, with or without depression or anemia. I think it's very complex situation context, and so it's multiple burdens. We know double burden and triple burden. I think this is much more than that, and it's probably I mean, we may not find an answer for this in this presentation, but I will try to give you some insight into the issue of labeling and how we can actually contextualize the new nutrition standards for the purpose of regulating the nutrients in prepackaged foods and nutraceuticals. And as you all know, nutrition labels is the most prominent source of nutrition information, but it requires a lot of education. Even educated people, I don't think they even read this part of the information what is given on the prepackaged foods. Most of us will look at the cost first and then probably the expiry date and then take the product. So it is very important for all of us to educate public on this and make that awareness about the nutrition component in all these things. Next one, please. We have a gazetted regulation. It is known as Food Safety Standard Labeling and Display Regulation, which has come into gazetted during 2020, and the compliance for this regulation is from 1st July 2022. That means by 1st July 22, everybody has to comply with the regulation, whatever is given in this part of the regulation. Now, we will discuss only about the nutrition component. This regulation provides the prepackaged food to be labeled, especially the nutrition information, per 100 grams or 100 ml or per pack. I mean, it is normally given on the back of pack. So a prepackaged food will have front of pack where they will have the normal name of the product. On the back of panel or on the side, if it's a rectangular box, you will have on the side that is known as information panel or back of panel. You will have this information given in a box. So this has to be, because it's easy if I mean, it is supposed to be given in a particular format so that it is easy for the consumer to compare between products and where to look for the information rather than, putting all over the box. So it is very important that they should be using a specified area for this purpose. And the information should be given per serve, and the information should be given as per percent contribution to RDA. I mean, this is what actually is existing one. And then you have to give the energy value in kilocalories. Also, there are the macronutrients, especially the proteins, carbohydrates. They should be given in that order. Total sugars. Under carbohydrates, you have total sugar, added sugar. Then under fat, total fat, saturated fat, trans fat, and of course the cholesterol and sodium. These are the mandatory nutrition information that is required to be given on a prepackaged food. Though this is the most important part of labeling regulation. And also the FSSR, that is Food Safety Standard Regulation, permits addition of vitamins and minerals as an optional ingredient. Okay, so so the labeling of that is different from what is actually mandatorily given. They have to be given only when it is present, and also if you want to take it's a source for this nutrient, the vitamins and minerals, then you will actually illustrate or give that information on the label. And most of this information about the macronutrients, whatever is given in this mandatory package, is based on the acceptable macronutrient distribution range, AMDR. This has already been discussed. Next one. Yeah, see, when you look at this one, there is no difference between the previous one and present one, because the energy and the energy, deriving nutrients, carbohydrate and fat, they are all, we always apply EAR only. The average intake is what is actually used. So there is no difference between the existing regulation and also with the new, if you apply the new information into the existing regulation. Look at the energy now for any prepackaged food. We consider a denominator of 2000 kilocalories, because on an average, that is what is the per day calorie intake, and there is no change in terms of that. Protein, of course, there is a reduction in terms of the, because you have EAR and RDA for protein. So earlier we were using 60 grams of protein as the value, but current regulation, I mean, standard is about 40 grams. And so this gives actually, looking at the value, there is a reduction in the protein content, but all other things, carbohydrate, total sugar, added sugar, total fat, saturated fat, they're all within the range given for these nutrients. With coming to the vitamins and minerals, I will show you the change with respect to the previous nutrient reference value and the current nutrient reference value. There are certain nutrients which are on the, which has to be reduced, but there are certain nutrients that needs to be increased because of the change in the computation that is used in 2010 and 2020. The nutrient that needs to be reduced, of course, iron is one of them. And iron, because there is a concept also changed here in terms of the bioavailability component. Earlier we were using a 5% bioavailability. Currently it has become 8%. So naturally there is a reduction in the EAR and the RDA. Vitamin A and niacin, these are the three nutrients that that actually will reduce based on the new EAR values. And increase, of course, vitamin C, vitamin B2, vitamin B12. Vitamin B12, as earlier we have the requirement was only 1 microgram. Now it is 2 as EAR, and maybe it's around 2.4 for RDA. So there is actually increased requirement in terms of vitamin B12. Then calcium. Of course, there is a large increase in requirement for calcium from 600 to 800, and folate also. Next one. Yeah, this is actually, I have given the information for you to see the values: RDA 2020, then EAR 2020, and RDA 20. And also, like, Dr. Anura was saying about harmonization, I have put the nutrient reference values, which is adopted by Codex. I mean, they are now very close to what is actually been given in the internationally adopted value. But you can see there are some nutrients, there is no change, like zinc, B1, B6, and vitamin D. Vitamin D across the with the time there is not much change in terms of the values, because it is actually a projected intake, and across the age group also there is no difference. Both vitamin B12 and vitamin D, there is no difference in terms of intake across the age group or gender, and also for vitamin D also the same holds good. Next one. So this is what is actually we can expect in the new regulation if you are actually adopting the new national reference standard for all this nutrient, that is the NICMR 2020 book. Now, coming to the most important aspect of the this regulation is the fortification of foods, which is already again gazetted in 2018. See, I was actually recently, we had a brainstorming session, and we actually tried to compute the probability of inadequate intake in the population, and derive the fortification standards for all these nutrients, whatever is being now used for fortification. Now, salt is fortified with iron and iodine. The oil is being fortified with vitamin A and vitamin D. Milk also vitamin A and vitamin D. Wheat flour and rice, these two are fortified with iron, folate, B12. And you can see there are two vehicles for now iron, and there's a possibility of layering of this in the population. I mean, it's actually factual, because without salt, I mean, these foods are not consumed. So there is always a layering of this one. So this is a problem when you are using multiple vehicles for fortifying the same nutrient. So one of the recommendations we had in our brainstorming session was use only one vehicle and one nutrient for correcting the deficiency. Now, the important thing to note for the particular dialogue is that we never considered pregnant and lactating women for computation of these values, because they are a special group, and we have to use the group which actually has highest inadequacy other than pregnant and lactating women. And of course, you have the infants are also not considered, but the remaining group is considered, that you take a value which has the highest inadequacy, and from that you compute and use various combinations and look at the value which actually superimposes. You get a 50% inadequacy, and also nobody getting into a very small proportion going into the TUL side, or that means nobody is getting into the excess side. Next one. Next one, please. Yeah, previous one. Yeah, this is actually what we have now derived using the new NICMR 2020 nutrient recommendations. I have given the first, the second and third column is related to 2010 and what is the current fortification level, and the last two columns, the one is about the target group used for computation. Everywhere you find the 16 to 18 year girls or boys are actually having the highest inadequacy, and used that as their the value for computation of fortification standards. And you find the last column, the proposed change from the present one, if there is a change. Now for iron, now remember here we are proposing only one vehicle. So if you are using serial, there is no change in terms of the fortification level, because it is coming to the same amount, but you cannot have two vehicles. Folate, you can see, I mean, there's no fortification required, and we recommend only targeted approach. You don't need probably, to be added to cereals. Similarly, vitamin B12, there is no need for fortifying, because if you fortify also, you need a large amount of B12. It comes to around 8.1 microgram per kg. And that also between the different target groups, you have some getting into it's still inadequate when use 8.1 microgram per kg. So it's better to go for a targeted approach supplementation rather than fortify. So we actually suggest only iron to be fortified at this level, and there's only one, either salt or cereal, not both. Then coming to the vitamin A and vitamin D, both, I mean, it is at the existing level itself, because the difference what you get is almost same, and also the fortification level seems to be the same. So there is no need to change from the existing level. Also, the vitamin D also is very close to that. So these three are probably, there is no need to change the standards, but you cannot have more than one vehicle at a time. Next one. Coming to the other important one is about nutraceuticals. Now that is actually flooding the market, and you need strict enforcement on what they add and how much they add. So under this regulation, you have health supplements, nutraceuticals, food for special dietary use, food for special medical purpose, functional foods, and novel foods. So this also is in gazetted, and it is in operation. Now, except the food for special dietary use and foods for special medical purpose, the other groups of supplements, health supplement and nutraceutical, functional food, and novel foods, I mean, the recommendation, the regulation says you can add up to 1 RD of vitamins and minerals. So that's one we need to consider. But the other two, foods for special dietary use and foods for special medical purpose, they are all specially processed or formulated to satisfy particular dietary requirements, which may exist or arise because of certain physiological or specific health conditions, like what we are talking about, low weight, that is thinness, obesity is another one. So then diabetic, high blood pressure. So these are the conditions where you can have FSDU or FSMP type of products, which will be always given under supervision. And also the pregnant and lactant. So in the whole regulation, I have seen only this product probably which can be considered for this particular category, the maternal nutrition, that is pregnant and lactating women, because there is always a formulation like you have the infant formulation. This also is specific category, which it's very difficult for to satisfy all the vitamins and minerals at a particular level. For unlike the other groups or other categories, they require specific requirements, and their requirements have to be complete in terms of all nutrients. And also the regulation says in these products, like in FSDU and FSMB, you can add higher than on RDA, but not exceeding the limits of vitamins and minerals specified in Schedule 3. That schedule actually gives the, what is the level you can add to FSDU and FSMB. It is higher than 1 RDA. It's sometimes 2 RDA or 3 RDA, but it is below TUL, but it is higher than 1 RDA. So this is based on formulations, and which is scientifically validated, tested, then only this can be actually given and will be approved as a product and given to for public use. Also, in nutraceuticals, there are so many plants or botanical ingredients that is being included. There are about 400 of them. Okay, all these nutraceuticals, many of them, if you look at, actually there is an advisory for all these, not recommended for children and pregnant mothers. So the nutraceuticals are again, we should be very careful about giving them to this category. With respect to these recommendations, these regulations, RDA less than, not exceeding RDA for health supplements and nutraceuticals, and you can exceed more than 1 RDA. My suggestion would be to limit for health supplement, maybe to EAR for general health supplement, and for FSTU and FSMP, you can have EAR to RDA, because it is a level that actually needed for certain categories, and they have to be again, experimentally or established that there'll be efficacy tested with this type of products. So this is probably what I wanted to highlight for the group, because I was looking for a regulation that specifically address the objective of this dialogue, that is actually the at-risk mothers suffering from obesity, extreme thinness, with anemia or without anemia. Of course, anemia, this category has a specific guideline, and they have to be adopted. Next one. Thank you. I would stop here, because we would like to discuss more than giving, because it's an evolving area, and you need to actually understand more about from the clinicians, the practitioners, what is actually that is required from the regulators. That also is very, very important, because this dialogue, that's why I like this dialogue, to understand what the practitioners want from the regulators. Thank you very much.
Thank you very much, Nair sir. That was quite an exhaustive outlay of what we as clinicians need to understand as well. Now, we will invite questions from the floor, and as of now, I don't see any relevant questions in the question box. So my first main question to you, Nair sir, is that while you say the consumers, when they pick up the packaged food, they will look at the expiry date and they'll also look at the cost, and that's about it. Okay. So the practical question is, how much percentage of the population in India actually go for packaged food because of the affordability issue in the first place? And then even the educated, as you said, even the doctor community may not really know the implication of, even if they look at every line of whatever is printed out there, it may not make any real sense as how it is meant to be. So what is your response to that?
Yeah, the usage of packaged food is very, very less in our country. I think there are some studies. I think the exact figure I won't be able to give you, but I think somebody in the group probably can give it, including Dr. Subbarao or somebody if he's there, because they have done some studies. they are, I mean, this is very important in terms of educating public on this, either through media, okay, visual media and print media everywhere. I think this has to be done, educating the public with respect to how to understand, at least to go through the nutrition information, what is there, what to look for. And now probably with we are in the process of coming out with a front of pack labeling to conceptualize and make the whole thing into a simpler form to make the consumer aware what is the healthfulness of a product. So it actually is in the process, and probably within we are again discussing with the all stakeholders. These are all requires a lot of debate with the stakeholders. A change in the the document itself, national document from 2010 to 2020, especially the food business operators, they have a lot of issues with it in terms of their investment and their formulations. Everything is a issue. So we always give them sufficient time to implement certain regulation, and that's why the time is always given. But public has to understand the information and take it forward.
Sure, sir.
It has to be education. That's all. Nothing but education.
Yeah, absolutely. Because I think now people have come to terms with at least the green dot and the red dot, the vegetarian and non-vegetarian. Something it's kind of sunk in their heads.
Yeah, that's why we are coming out with a logo for the quality or the product quality in terms of HFSS, that is high fat, high salt and sugar type of product.
So Ashish Bhaltalik asked, can you please give your view on the health star rating? Is there anything called the health star rating? Because that question is little, halfway
he is asking me to describe about that in terms of front of pack label. I mean, that is still we are in the initial stages of developing the logo for it. It's like a logo, like the red spot, brown spot or green spot, or even the fortification. You have a F plus like that. This also is a health star rating. I mean, we are almost probably coming to implement that, but it takes time for us to. It is still in the discussion points.
Yeah. So one last question from my end again on fortification. Is there a common positive view on double fortification of salt, as in iodine and iron, or are there? Is it shrouded with some controversies where some people think that it is not one of the best things to do? That's point number one. The second thing is, again, when the wheat flour, which is also one of the common staple food that many in India would eat, again, they'll go to the chakki and they'll get the wheat pounded and get it home rather than buying it in a packaged fortified stuff. So how do you think in the long run we will address it to actually reach the last mile, the fortified stuff?
See, I am probably not very happy with fortifying iron. Iron has a different physiology of absorption and the mechanism of excretion. The diet plays a major role. So that's why I think Dr. Raghu presented how to improve the bioavailability. Without that, I don't think we can ever solve the problem of anemia by including foods that is rich in ascorbic as part of your meal. Okay, so you take a guava as part of your meal, you are doubling your absorption.
Yeah.
I mean, it's enough for you to, you don't have to add any extra. That probably is solve many of these things.
Right.
Fortifying without this, you don't reach anywhere. All your studies, meta-analysis also shows very poor impact on many of these things, especially wheat flour or rice fortified with iron and even salt. You get an improvement of only 0.2 gram per 100 ml over a period of 3 years or 4 years.
Right.
That is not going to change your anemia prevalence at all.
So Sirimao Nair asks again, we have iron only 1100 ppm in the salt. Adding one more vehicle at this low level brings so much changes as being discussed. Is what perhaps you've already addressed that.
Yeah, I think any addition to your your intake is going to shift your distribution. So we don't want to go beyond your EAR. If it is getting superimposed that at that level itself, you don't want another vehicle to be added to that and increase the iron load in the population. Already you have and another thing I would suggest is if supplementation is in place, there is no purpose of adding iron to any vehicle and giving to the population.
Right. Thank you, sir. Suparna, one last question to you as well. When you said Jharkhand and then, there is 100% deficiency of so many things. Sir mentioned the triple burden. Of course, it is there, the burden of obesity as well, which is, swinging for more than 37% as per the recent reports. So they're not eating right, on the whole. Either it is too little, too much, not right in some way or the other. So are there any studies underway to address what this rising obese population will actually need to consume?
So that's what I said at the beginning, that we need to look at the two ends of the spectrum being demonstrated at the same time. And we have people at various stages, and this is what we call nutrition transition. And we being a developing country, the same thing has been experienced in different other countries as well. So we need to strike a balance between, and that's the reason why we need to carefully look at our nutritional requirements. And while assessing the actual intake, perhaps we have to go with a realistic cutoff, which will make sure that we unnecessarily do not make a section of the population being, stamped as undernourished just by comparing it with the RDA and overfeed them. So that is the reason why we want to stick to the EAR. And if I say Jharkhand, we are looking at a very specific group of malnourished population who are in geographically isolated areas. So this case study perhaps is not a very great reflection of why EAR is justified or RDA, because even with EAR, we are seeing such low levels of intake when we are comparing. So that gets magnified when we are looking at the RDA on top of it. So had we been able to show the same thing in an urban population, for example, I think the difference would have been much more evident, wherein we would have found a good percentage of population was meeting their requirement in a reasonable well manner, whereas only a small proportion might be at risk. But if we put RDA, then perhaps we are, making a huge set of population being called as not sufficiently consuming enough diet. So we have to looking at both the ends of the spectrum and then looking at totality, because we cannot deny that people are consuming lots of processed food from the market. And even in the lower income group also, the consumption of packaged food is increasing because of whatever reason, the pricing and all. It is affordable. So we have to be careful in keeping in account the entire food environment of the population, and not only just restrict ourselves to thinking that they need fortification, they need supplementation. Perhaps the dietary diversification is something which needs to be given due importance, and in all our programs that should come up. Like, if we are talking about the take home, and just giving the example of the community who I worked with, we found very bad dietary diversity despite having access to a diverse range of food items. So education will perhaps make a lot of difference, and we do talk about information education and communication and behavior change communication, but perhaps this has to be a part and parcel of all the nutrition programs that we are talking about here.
Absolutely. Thank you, Suparna. We as clinicians notice that right across the country, any economy, any educational level, any geography, when the pregnant woman comes, one of the first questions that the family will ask, what should she be eating, etc. And then, that is the key question which we are always asked, but unfortunately, I think it's just pushed under the carpet because of inadequacy of a precise, quick way of putting forth in the manner that they understand what they really need to eat. So I think it's a very good opportunity. It's opened our eyes into many, many issues where we could do better than what we are already doing. So on behalf of the whole team here, Suparna ji and Madhavan Nair sir, we thank you very, very much. And I hand it over back to our pillars of e-dialogues, Tina, Richa, Bharti ji, and the team. Namaskar. Thank you.
Thank you.
Thank you very much, Dr. Hema, for leading an enriching panel discussion. And I'm very grateful to our panelists, for sharing their wisdom with us today, of which, many of us are having doubts, and most of the doubts were clarified. Now, before we close the session, I would like to request Dr. Bharti Kulkarni, to summarize us on the key takeaways from the webinar today.
Thank you, Tina, and thank you, Hemaji, for conducting a very lively panel discussion as always, and it has been a very, very delightful experience. I am sure all the participants will agree with me that we had a very enriching session today. We started with opening remarks from Dr. Korpad, who highlighted that pregnancy and lactation are very stressful events in terms of nutritional requirements, and as of now, we do not have trimester-wise nutrient requirements, although they are needed. So there is a lacuna and there is a scope of more research and work there. Followed by that, we had an extensive presentation by Dr. Raghu from NIN, and he highlighted many important points which underpin the concepts of estimated average requirements and recommended dietary allowances. He highlighted the inherent variation in the requirement of the population, which we need to understand. And therefore, these concepts are very important, underlying the concept of EAR and RDA. He also highlighted the differences in nutrient absorption, tissue size, reabsorption, and excretion across different individuals in the population. He also described how requirements are derived based on what kind of studies are needed for this. And then he also explained the metrics of EAR, RDA, as well as TUL, which was the first time described in the 2020 nutrient requirements book. And he highlighted the fact that RDA is a level of requirement which is needed only for 2.5% of the population. So when we compare our intakes with RDA, we tend to overestimate, and Dr. Suparna also highlighted this fact. He also gave us a way of calculating the risk of inadequacy. He highlighted that it should be assessed by comparing with nutrient requirement distribution. So we should go for probability of inadequacy by comparing with the distribution rather than one single value. And he also emphasized that goal of interventions should be to achieve the risk of inadequacy or adequacy by 50% to 50%. I think this is very important to understand. We cannot expect that the population distribution, everyone will reach the RDA. I think that's a sort of conceptual misunderstanding many people will have. And he showed it with examples of vitamin A and iron, that if we have multiple sources of fortification, in order to reach the RDA, we might land up in substantial proportion of population going above TUL. Then we had a very enriching discussion following that, and Dr. Hemlata gave example that how in the new guidelines, the focus has been on improving dietary diversity, not by although the energy requirements when we use and other nutrient requirements seem to be reduced because we are using EAR rather than RDA, but the current effort has been to focus on improving the dietary diversity, and this is should reassure people who are concerned about the implications of switch to EARs for the public health programs. We then had a very nice presentation by Dr. Suparna, who showed with an example of her study in tribal women in Jharkhand. And she also showed us how she used statistical modeling to derive the usual intakes and how she used the probability approach to estimate the inadequacy. That was a very, very useful exercise. And she again emphasized that EAR is the right metric to assess the population level inadequacy. Followed by that, we had a very interesting presentation by Dr. Nair, very interesting and informative indeed. And he gave us information about the impact on the labeling, and he highlighted that there will not be really any major change because of that. There is difference in the iron requirement, but that is also contributed by difference in the our understanding of the bioavailability. He also gave us ideas, information about the products for pregnant and lactating women, which are actually come under the special foods. And he also gave us information about the fortification, and that's quite a debated topic, and many people are wanted to know about it. And he has given a very clear picture that it's multiple foods, if when they are fortified with a same nutrient, that's completely undesirable. And he focused on dietary diversity and improving absorption, especially of iron, as a way ahead for reducing anemia. So overall, I feel our participants have learned a lot in today's discussion. I'm very, very thankful to our speaker, Dr. Raghu, and our panelists, Dr. Suparna Ghosh and Dr. Madhavan Nair, for sharing their knowledge and wisdom with all our participants. And I thank Dr. Hema for conducting the panel discussion in a very interesting manner. Dr. Vani is also with us. She's the one who actually stimulated the series of maternal nutrition e-dialogues. I would request Dr. Vani to say a few words because this is the last e-dialogue in our series of the annual thing. Dr. Vani, are you there?